Hello, everybody. Please, can you tell me that the voice and the screen are clear or not? Can you hear me and can you see the screen? You can write in the chat. Okay, good. So, hello, everybody. Again, I'm Dr. Mohammed Ghazal. I'm a general medicine and dentist teacher. I'm teaching medical students in a lot of countries, some European countries and some Arabian countries like Germany, Turkey, Canada, US, and Russia, Ukraine, and also in some Arabian countries like United Emirates, Egypt, and now, of course, in Kyrgyzstan. So today we're going to study together some tough subject. I don't like to use the word tough or hard because it's not hard, but it's a little bit complicated, but I hope you can do it. I hope we can make it easy for you. The pathology, and I think that is the most wonderful subject in the first 3 years in medicine. So today we're gonna take the first class in pathology, and we will take basic general pathology. And I hope you will enjoy it. And don't worry, the class will be recorded, and we will post it on our channel or our YouTube channel. So let's start. And don't worry, for each topic we have PDF, and I will send it on your group. So I think I've sent that PDF before 3 days, and this PDF for the first 3 classes. Today we will take the first topic in pathology. And please, I love a student to share with me. So I muted the mics, but don't worry, when I ask some question, I will open the mic and you can speak and you can share with me, because I love the student to share with me. And don't worry, if you answer, if you did a mistake, it's completely normal. I will correct for you. So, but please share with me. When I ask question, if you know any answer, correct or incorrect, just share with me, and don't worry, you are here to make a mistake, and I'm here to correct for you. So today we will talk about a very important topic. It's called adaptation. Adaptation. And that PDF, this PDF include cell injury, and in cell injury we have a lot of topics. We have reversible cell injury, and we have something called irreversible cell injury, and deposits and adaptation. I like to start with adaptation. So today we will talk about a very, very important topic. So if I ask you, what does it mean, adaptation? What does it mean that the cell will adapt with something? So what does it mean the cell will adapt with something? So I'll open the mic and you can so you can speak. So anybody know what does it mean, adaptation?
Please don't understand.
Yeah, who's gonna share with me?
Sir, it means when cell is damaged, cell will try to be in normal in its normal shape or function normally.
It's a little bit correct, and you said something incorrect. So thank you. And something is anyone else who wants to share with me? What does it mean, adaptation of the cell? Okay. Who's gonna share? Yeah, who opened the mic?
Sir, it may be cell behaving like its environment.
Yes, yeah, it's good. It's a good answer. Thank you. So your friend will first say when the cell damage. It's not damaged completely, but it's not correct word. So let me explain. Adaptation. When the cell are faced some stimulus, some abnormal stimulus. This stimulus or something abnormal in its normal environment. So there is some stimulus or something abnormal occurs in the cell. So the cell will try to adapt. So the cell will try to compensate this stimulus, this abnormal stimulus. So the cell will try to face this stimulus. So how the cell will adapt with the stimulus? We have 4 features of adaptation. 4 features. First one, it's called atrophy. And don't worry, we will explain everything. Second, hyperatrophy. Third, hyperplasia. Fourth, metaplasia. So the cell will try to adapt with the stimulus, with the abnormal environment, with these 4 features. We'll explain every feature in these things. Atrophy, hyperatrophy, hyperplasia, metaplasia. Okay. So the adaptation, it's like a change occurs in the cell. But what are these changes? A change will happen maybe in the size. The cell will be bigger or maybe smaller. Maybe in the number. The number will increase or decrease according to the stimulus. Maybe function. The cells will try to hyperfunction or hypofunction. The cell will try to increase its function or maybe decrease the function according to the stimulus. Or maybe the type of the cell, metaplasia. The type of the tissue will completely change according to the stimulus. So adaptation, it's reversible changes, reversible. It's a very important word. Reversible changes, but all these features are reversible. Not exactly. Almost they are reversible, but we will take some features they are not reversible. They are irreversible. When the cell change to try to adapt to the stimulus, it cannot come back to the normal nature. But almost features they are reversible. So what the change will occur in the cell? We say the change will be maybe in the size, maybe in the number, maybe in the function, maybe in the type of the cell. Okay. So adaptation, it's almost reversible change, except in something we will talk about later. These changes can occur in number, in size, function, or type of the cell. They can be physiological or pathological because we have physiological stimulus in the body, physiological changes or pathological changes. For example, when the girl gets pregnant, of course, the uterus, when the girl is not pregnant, it's different than the uterus when the girl is pregnant. So we cannot call that it's pathological. It's not a disease. It's physiological. But in sometimes we have pathological changes. So adaptation can be physiological or can be pathological. All these, the first 3 features, they can be physiological or pathological, but never, metaplasia can be never too physiological. It's always disease. Remember, the first 3 topics we will talk about now, they can be physiological or they can be pathological, But please don't tell me that metaplasia can be physiological or pathological. It never can be physiological. It's always pathological. So again, adaptation, when the cell face some change in the body, some stimulus in the body, so the cell will try to adapt to the change. How it's going to be adapt to the change? It will change the size of the cells, number of the cells, function of the cells, type of the cell. These changes can be physiological or pathological. But please remember that the last type of adaptation, metaplasia, can never be physiological. It's always pathological. It's always disease. So don't worry. Each 15 minutes, I will look on a chat if anyone has any question. Okay, so now we're gonna talk about atrophy first, then hyperatrophy, then hyperplasia, then metaplasia. So let's start with atrophy. Atrophy, the letter A means decrease. So atrophy, it's decrease, but decrease in what? In size of the cell or in the number of the cell? Atrophy, it's basically decrease in the size of the cells, but it can be associated with the decrease in number of cells. But to call it atrophy should be decrease in size. So it can be or cannot be associated with decrease of number. So atrophy, decrease size of organ due to decreased size and or decreased number of cells. So if I ask you, in atrophy we have physiological change, physiological atrophy, and pathological atrophy. If I ask you, do you know an example of physiological atrophy? So the mic is open. Anyone know any type of physiological atrophy?
Yes, sir. There is a loss of hormone stimulation in the menopause or post-partition after the delivery, vaginal atrophy.
Okay, and else?
Sir, maybe the aging factor can cause the atrophy of the brain cells.
No, atrophy of the brain, it's not physiological. I'm talking now about physiological, normal atrophy. Anyone know any example of normal atrophy?
Sir, muscles atrophy maybe.
What?
Muscles atrophy.
No, of course it's not. It's not normal. It's not normal.
Atrophy of thymus gland during childhood.
Yeah, excellent. Thank you. Okay, so the atrophy, the physiological atrophy. If I ask you, you now are 20 or 25 or 30 years old. Is your thymus now is similar to the thymus of a 10 or 12 years old child? Of course not. Of course, thymus, it's a primary immune organ present in children, only in children. With advanced age, the thymus start to atrophy. The thymus cells start to die off. So the thymus after puberty, the thymus will be decreased in number of cells and the size of the thymus will be decreased. Your thymus now, it's smaller than thymus of the children. So the first physiological atrophy, it's completely normal. It's normal. It happens normal. So the thymus, it's immune organ present only in children, and after a specific age, the thymus will start to die off. The cells will be die off. So first thymus after puberty. When you work in the hospital, you will find a lot of people, they have something called appendicitis. ITIS means inflammation. Inflammation of the appendix. Appendix, it's located behind in the large intestine, in the colon. But when you find some patient with appendicitis, all of them, they will be young age. You will never find out some patient 60 years old or 70 years old who has appendicitis. Why? Because appendix present only in young age, in 20, 30, 40, but after that, the appendix will start to decrease in size and decrease in number of cells. So the appendix will start to atrophy after some advanced age. So in the hospital, you will never find someone 60 or 70 years old with appendicitis. So appendix start to atrophy in old age. It's normal. Ovaries, as your friend said, in ovaries after menopause, because the young lady, she can get pregnant, and the ovary will start to secrete the sex hormones. But in after menopause, the girl will stop get the pause will stop get the pause. It's called menopause. So the ovary will start to shrink and decrease in size and the number of cells, because after 45 age, or maybe after 50 years, the ovary will start to shrink, because it will not be used anymore as a young lady. So the ovary will start to be atrophied. Also in brain and heart, but in brain and heart we call it senile heart, or senile brain. What does mean senile heart or senile brain? After some age, in old age, 70 or 80, maybe if you have a grandfather, you notice that your grandfather start to forget something, start to forget a lot of things. Why? Because some brain cells start to be atrophied. And also in the heart, because the heart will not be strong as young people, so the heart cells will start to be atrophied, because they will not work very hard like young people. The heart will not pump a lot of blood like in young people. So in old age, the heart cells and the brain cells will start to be atrophied. It's completely normal. So the physiological atrophy, it happens in thymus, in the appendix, in the ovaries, and brain and heart cells. If I ask you, what is the common thing between all of these examples? What do you think? What is the common thing between all of these things? What's the common thing? Yeah,
Age
Sorry, age
factor.
yeah,
factor.
excellent. Yeah, excellent. The age, it's all related to age. All the examples, they start to be atrophied after a specific age. For example, the thymus after puberty, the ovary after menopause, the heart and brain in old age, the appendix in old age. So they all are related to the age. Okay, now the pathological atrophy. And before explain the pathological atrophy, so let's talk about how the cell can get the nutrition, how the cell can get the supplement. This a cell. We have a lot of supplement which coming to the cell, like for example, blood and oxygen. Also, the nerve. There is nerve supply. What else? Hormones, can also affect the cells. So we have a lot of things which can affect and make the cell work properly, like hormones, the nerve, the blood supply, the oxygen supply, and also the nutrition, like protein, lipids, carbohydrates. So if some stimulus cut off the way of these things to go to the cell, so it can cause pathological atrophy because the cell will not get the supplement anymore. For example, in something called ischemia. Ischemia means that the blood vessel which supplies the tissue, so this blood vessel is blocked. So there's no blood or oxygen will go to the cell. So there's no blood or oxygen. So the cell will start to be very sad, and the cell will start to die off because there's no enough blood, there's no enough oxygen. So the whole organelles inside the cell will not get the nutrition, will not get the blood or oxygen, and a lot of metabolic reaction will stop, and the cell will try to shrink and die off. For example, in some disease called this the kidney, and here the renal artery. Renal means kidney, the artery which supplies the kidney with blood. So, for example, some patient get atherosclerosis or some stone which block the blood supply to the kidney. So what's going to happen to the kidney? Of course, the kidney will start to shrink, and the kidney will start to die off. The kidney will start to die off and shrink because there's no enough blood or oxygen to the cells. So the cells will start to decrease in size, decrease in number, because the cells will start to die off. There's no enough blood or enough oxygen. It's called ischemia. Also, in some neurogenic effect, the nerve cannot supply the cells. For example, the muscles. This skeletal muscle, and we know that each skeletal muscle has its own nerves. So if the nerve cut off, so there's no nerve supply to the muscle, so the muscle will start to die off because the muscle will not work properly. There's no nerve supply, there is no enough innervation to the cell, so the muscle will stop working, so the cell will start to die off. Also in hormones, we talk in endocrine system, and also we will take in endocrine pathology. You know that this the hypothalamus, and this the pituitary gland, and you have here cute gland, it's called thyroid gland. We know that hypothalamus is the master, he's the king. Thyroid gland cannot secrete its hormone without the order from the hypothalamus and pituitary gland. We know that hypothalamus will secrete thyroid releasing hormone. Thyroid releasing hormone will go to some cells in the pituitary gland. It's called thyrotroph, and it will give the order to thyrotroph to release thyroid stimulating hormone, and thyroid stimulating hormone will go to thyroid gland and give it the order to secrete thyroid hormone T3 and T4. Imagine if something happened to thyrotroph, so pituitary gland will not secrete TSH anymore. So there is no hormonal secretion or hormonal order to thyroid gland. So thyroid gland will stop secretion T3 and T4, and the cells will stop working. And we know that the organ which we don't use it, we lose it. The organ which we don't use it, we lose it. So thyroid gland cells will stop working. After that, will start to die off. Because when we explain the endocrine system, we will know that TSH it plays very important role in hypervascularity to thyroid gland. It increases the blood supply to thyroid gland. So TSH will not be secreted anymore. So thyroid gland will not get hormonal order or blood supply, enough blood supply. So the cells will start to die off. It's called hormonal pathological atrophy. So we talk about the ischemia, blood and oxygen, insufficient blood and oxygen. Also, we talk about the nerve and hormones. Also, we have something called pressure stimulus. What does it mean, pressure stimulus? Pressure stimulus. Here, the heart, this is the heart. And here we have the aorta. And we know that the aorta, it's going to the thorax and give some branch called thoracic aorta. And after that, we'll come down to the abdomen and give another branch. It's called abdominal aorta. In abdominal aorta passes in front of the abdomen and in front of the spinal of the vertebral column, like here. See, it's abdominal aorta. It passes in front of the vertebral column. Maybe something happened to the abdominal aorta. It's called aneurysm. It's called aneurysm. What does it mean, aneurysm? This is the abdominal aorta. Due to some effect, maybe hypertension or other effect, we will study aneurysm in details, but later. So due to any effect, for example, like hypertension, the membrane of the blood vessel will start to be very weak, and after that the blood will start to accumulate here, and then some bulge will be forming, and this bulge will compress on vertebral column, because we said that we have vertebral column behind the abdominal aorta. So when the abdominal aorta form a bulge, this bulge will compress the vertebral column. And of course, when compress the vertebral column, it will compress the arteries which supply the vertebral column. So what's gonna happen? The vertebral bodies we have here intervertebral disc between each two vertebrae, and here we have the vertebral bodies. So we know in anatomy that the vertebral body has blood supply, but the disc does not have blood supply. So there's nothing will happen to the vertebral disc, but the vertebral body will start to die off. And after some time, after the body will start to die off, then the disc will be dislocated, because you know what causes stabilization of the disc? The vertebral bodies. The vertebral bodies, they compress on the vertebral disc and make it very stabilized. Now the vertebral bodies start to die off because the abdominal bulge compress on the arteries which supply the vertebral bodies. So the vertebral bodies will start to die off, And after that, the vertebral disc will not be stable anymore. They will be dislocated. It's called pressure atrophy. Pressure because the abdominal aorta valve give a pressure or compress on the arteries which supply the blood artery for vertebral bodies. So we talk about ischemic atrophy, pressure atrophy, neurogenic atrophy, and hormonal atrophy. And we have something called disuse. Disuse, we said that uh, the organ which you don't use it, we lose it. And funny story. When I was teaching in Canada, I was teaching some students, and I asked them, which organ, if we don't use it, we lose it. Someone said the brain. If we don't use our brain, we will lose it. So it's not, of course, it's not correct. So disuse here, for example, in some patients which have fracture and they don't move for 6 months or for 1 year. So the muscle which you don't move it, you don't move it for a long time, so the blood supply will be disrupted, and after some time, the cells in the muscle will start to die off. So it's called disuse. And also we have nutritional atrophy. For example, in something called marasmus. Marasmus means severe lack of protein. You don't eat protein for a long time. For example, in very poor countries, they have starvation. They don't eat protein for 10 or 20 years. So we know that proteins are very important to form our muscles, because our muscle consists of protein. So in poor countries they get marasmus, and then we can get muscle atrophy. So again, the example of pathological atrophy, ischemic atrophy, when there's no blood or oxygen going to the cell, so the cell will try to die off. Pressure atrophy, and remember the most common artery in your body which can get aneurysm, it's abdominal aorta. It's called abdominal aorta aneurysm. And after that, some bulk from the abdominal aorta will compress on the arteries behind the abdominal aorta. These arteries supply the vertebral bodies with blood. So these arteries will be blocked because of the blood, and then the vertebral bodies will not get enough blood and start to die off. And a complication for that, the disc will be moved, will be dislocated. And neurogenic, of course, in the skeletal muscle, because we know that skeletal muscle need a lot of innervation. So if some nerve cut off, so the disruption in nerve supply, so that's the patient will start to get neurogenic atrophy. Hormonal atrophy, we said, like in pituitary gland, we have some problems, some disease which can affect the thyroid trough, which secrete TSH. So there is no TSH anymore. So thyroid gland will not work properly, and the cells will start to die off. Why? Because the cells are present to secrete T3 and T4. Now we are not working. We don't secrete. So why we will stay here? The organ which we don't use it, we lose it. So the cells will start to die off. Nutritional atrophy, like in severe protein starvation, like marasmus. In poor countries, they don't eat protein for a long time. So then we will start to get muscle atrophy. Okay, if you look at atrophied cell, what you gonna say? What you gonna see in the atrophied cell? The morphology of the atrophied cell. Of course, first, decrease in cell size. Why? Because we have the organelles. So there is no blood supply is going to the cell. There is no oxygen. There is no hormonal supply. There is no nerve supply. So these organelles were supplying with oxygen and blood. So now there is no oxygen or blood or hormone or nerve supply, so the organs will try to die off. For example, if the cell contain in the beginning, the cell contain 1,000 organelles. After facing some stimulus, abnormal stimulus, maybe they can decrease the organelles to 10 or 20 organelles. So of course the cell will try to shrink, the cell will try to decrease in size. After that, we have now we talk about the decrease in size or number. So what we call the increase in size or increase in number, anyone know? What does it mean increase in size? First, increase in size.
Hypertrophy.
Yeah, thank you, hypertrophy. And increase in number.
Hyperplasia.
Yeah, correct, hyperplasia. Okay, thank you. So now we're gonna talk about hypertrophy. Hypertrophy. So hypertrophy, it's increase in size. And please write down that hypertrophy, most cases in hypertrophy are physiological, and hyperplasia, most cases in hyperplasia are pathological, and we will explain in details now. And after explaining the examples, you will understand why most cases of hypertrophy are physiological and why most cases of hyperplasia are pathological. So hypertrophy, so it's increase in size of organ due to increased size of cells. The cells will be increased, so the organ as whole will be increased. Why? Now we have physiological stimulus and pathological stimulus. Physiological stimulus, can anyone please tell me some example of physiological hypertrophy? Physiological hypertrophy.
Muscle hypertrophy.
Yeah, thank you. Who's going to gym? Of course, most of you are going to gym. So before 1 year, your muscles are similar to the muscle size now? Of course not. When you go to gym and start to put resistance and put some weight on your muscle, so your muscle will face stimulus, the resistance stimulus. So the muscle will say, hey, that guy give a lot of pressure and a lot of resistance on the muscle. So we need to take a lot of protein. We need to get bigger and bigger and bigger to be able to resist this stimulus. So muscle hypertrophy, muscular hypertrophy. And what else? Anyone know another example of physiological hypertrophy?
Uterus enlargement during the pregnancy.
What?
Uterus enlargement.
Yeah, thank you. Yeah, that's correct. Okay, what else? So muscular hypertrophy, uterus hypertrophy, and breast hypertrophy. So let's talk about each one. During pregnancy, and also we will talk about the pregnancy in detail. We have a complete chapter talking about the menopause, the pregnancy, and the female sex hormone. During pregnancy, so this is the myometrium, and here, of course, the endometrium. When the girl gets pregnant, of course, the uterus will be different, will be increasing size. Why? To be able to contain the baby, the fetus. So the uterus, the ovary will start to secrete female sex hormone, very important hormones called estrogen and progesterone. Estrogen and progesterone. Progesterone will stimulate the cells, the glands, and the endometrium to increase in size. To increase in size. Remember, the progesterone will stimulate the cell to increase in size, to be hypertrophied. So the uterus will be increased in size to contain the full fetus. So it's called hypertrophy. And also in breast we have some ducts for secretion of milk. So these ducts will be increased in size because after some months you will get lactation. You will feed your baby. So the ducts under the effect of female sex hormone will be increased in size. So it's completely normal. It's physiological. So physiological example: muscle hypertrophy and uterine smooth muscle hypertrophy, and also in breast. It's physiological hypertrophy. Okay, pathological hypertrophy, and please write this word resistance. What does it mean, resistance? Let's take some example in pathological hypertrophy. Pathological hypertrophy. There's the heart, and this is the right atrium, the left atrium, the right ventricle, and the left ventricle. And here you have something called superior vena cava and inferior vena cava. It's a vein. Superior vena cava, it take the blood from upper extremities, deoxygenated blood, the blood which doesn't have oxygen, and inferior vena cava take the blood from lower extremities, which has low amount of oxygen. It's deoxygenated blood, and then the blood will come to the right atrium, then to the right ventricle. The right ventricle will pump the blood to pulmonary artery. And here in the pulmonary artery, the blood will be oxygenated, will get oxygen from the lung. And then the blood will come to the left atrium. Then from the left atrium to the left ventricle. Then the left ventricle will pump the blood in aorta, and after that to all body organs. So here you know that right ventricle pump the blood to the lung, and left ventricle pump the blood to the organs. In some diseases, some diseases can cause increase resistance against the blood. For example, if some person get pulmonary stenosis, something close the way in front of right ventricle. So what's going to happen to the right ventricle? Right ventricle cells will say, hey, there's something is blocking the way in front in the pulmonary artery. So we have to increase the strength of pumping. We have to pump very, very hard. So after some time, your cardiac muscle will try to be hypertrophied to compensate with this resistance. Typically, like your skeletal muscle, when you go to gym, When you go to gym and you start to increase the weight, so your muscle will try to get bigger. And also in the heart, if the heart gets some resistance, so the heart muscle will start to be atrophied, as well as in aorta. If something block the aorta, so the left ventricle will try to be hypertrophied to be able to pump the blood in front of this resistance. So it's called cardiac hypertrophy. Cardiac hypertrophy. And of course, a big heart, it's not a good thing. A big heart, it's not a good thing. Why? Because cardiac hypertrophy, the first step in very, very dangerous disease, it's called heart failure. We will explain everything about heart failure, but first step in heart failure, it's cardiac hypertrophy. Cardiac hypertrophy. Also, the hypertrophy can happen in stomach. In stomach also. There's the stomach, and here you have pylorus or pyloric sphincter. It's like a door. When open, the food will go to the intestine. Some disease called pyloric stenosis. Pyloric stenosis. The pyloric sphincter will close. So when the stomach try to push the food toward the intestine, it can't push the food because the pyloric sphincter is closed. Pyloric sphincter is closed. So what's gonna happen? Of course, the stomach will start to atrophy to be able to push the food with strength, with force. So we'll get gastric hypertrophy. For example, also in urinary bladder. Here you have urinary bladder, and here it's called urethra. The urine will go from the urethra to the will go from the urinary bladder to the urethra. For example, there's something is blocking the urethra. So what's gonna happen to the bladder? The bladder will start to contract very hard and will start to hypertrophy to be able to push the urine against this resistance. So it's all about the resistance. It's all about the resistance. When resistance increase, so the organ will increase the size of the cells to be able to push against this resistance. Also, here there's another example, but some books and some reference, they consider that their example is physiological, and some books they consider it's a pathological. It's compensatory. It happens in kidney and liver. For example, here the liver, and you know that liver has 4 lobes. Unfortunately, most of you think that liver have 2 or 3 lobes. Liver has 4 lobes. If you cut some part of the liver, it's called hepato means liver, hepatoectomy. Ecto means cut off. After some time, the cells will start to be atrophied to compensate the decrease in cell number. Also in kidney, Some patients they get kidney failure. Unfortunately, the kidney cannot work anymore. So we will cut one kidney. We will cut off one kidney. Of course, we cannot partially cut some part of the kidney. In kidney, we will cut it all. So what's gonna happen to the second kidney? Will start to be atrophied, the hypertrophied, to compensate the function of the second kidney. So it's called compensatory. The body try to compensate. You cut off one kidney, and so the second kidney will be hypertrophied to compensate the decrease in function. So some references they consider it's physiological, and other books they consider it pathological. So it doesn't make difference. Just understand that it's called compensatory. Physiological or pathological doesn't make difference. So now we finished hypertrophy. So we said that hypertrophy, it's increase in size of the organ due to increase in size of cells. We have physiological and pathological. Physiological in muscle, in uterus, in breast. Pathological, it's related to resistance. When the heart get a resistance, so the heart muscle will start to be hypertrophied to be able to pump the blood against this resistance. Also in stomach, when the pyloric sphincter is closed, so the stomach try to push the food into the intestine against the resistance. Also in urinary bladder, when you get some obstruction in the urethra, so the bladder will start to push the urine against this resistance, so the urethra, the bladder will start to be hypertrophied. So we talk about the atrophy, its decrease in size and or number. And also we have physiological and pathological. Physiological, thymus, appendix, and ovaries, and brain and heart. And also we talk about pathological, we said ischemic atrophy, ischemic atrophy like renal stenosis, pressure atrophy like abdominal aorta aneurysm, neurogenic atrophy when you get cut off in some nerve, and disuse during fracture when you don't move your muscle for long time, so you start to get muscle atrophy. Why you start to get muscle atrophy? Because during immobilization, when you don't move your muscle, so the blood supply will be decreased to this muscle. It's not working. So why we have to get to give it a large blood supply? So the blood supply will start to decrease. That's why the muscle will start to atrophy after immobilization. And also hormonal atrophy, nutritional atrophy like marasmus, severe protein starvation. And we say that in during morphology, it's decrease in cell size due to decrease in cell organelles. And hypertrophy, we said it's increase in organ size due to increase in size of the cells. Physiological and pathological, and we said physiological during pregnancy and exercise, but pathological due to increased resistance against the heart, the stomach, the bladder. And also we have compensatory, and we said you can put it in physiological or pathological. And morphology, of course, hypertrophy, it's increase in cell size and increase in nucleus size and organelles. Then we will talk about hyperplasia. So what's the difference between hyperplasia and hypertrophy? Can anyone please tell me what the difference between hyperplasia and hypertrophy? I will open the mic. Hyperplasia and hypertrophy. What's the difference?
increase in size of the cell is hypertrophy, and increase in the number of cells
Yeah,
is the
it's
hyperplasia.
yeah, that's right. It's one difference. Hypertrophy increase in cell size, but hyperplasia increase in cell number. And what else?
Hypertrophy is mostly physiological and hyperplasia is mostly pathological.
Yeah, excellent. Excellent. Hypertrophy mostly physiological, but hyperplasia we will see now it's mostly pathological. What else? Aisha, you have a question? You can ask. Aisha? Aisha, if you have a question, so you can ask.
Sir, Aisha's mic is not.
What?
Sir, I'm asking about that. When we talk about the hypertrophy in physiological condition, then you said that the increase in the breast size it is a physiological condition. But we read that when there will be extensive increase in the breast size, like in gynecomastia, so then there will be a pathological condition. So how we can say that it is only included in physiological condition?
Yeah, we will talk now about the pathological during breast. It's hyperplasia. We will talk about now. When the breast cells, it can increase in number and we can get hyperplasia. We will explain now, because mostly hyperplasia occurs in breast, and that's due to the effect of estrogen, and we'll explain now. So it's normally that the breast cells hypertrophied during lactation, but during within limits. But when we talk about the hyperplasia now, we will see that no, the breast cells will be increased in number so much, and we will get some disease. It's a very dangerous disease during hyperplasia of the breast, and we'll explain now. So we see the difference between the hypertrophy and hyperplasia, that hypertrophy increase in size, but hyperplasia increase in number. Hypertrophy mostly physiological. Hyperplasia we will talk about now, it's mostly pathological. Another difference that we have, and you studied in histology, that we have 3 types of cells according to the ability of division. According to the ability of division, you have non-divided cells. It's called permanent cells. If you lose some of these cells, you cannot restore the number again. If you lose it, you will not get it anymore. Like brain cells, you born with a specific number of brain cells and you cannot increase it, or if you get some damage in brain cells, you cannot restore the number of brain cells anymore. And we have dividing cells. Dividing cells, we have 2 types of dividing cells. Some cells called stable cells, and some cells it's called labile cells. Stable cells, they don't divide, but after being under some condition, they can divide, like liver cells. Of course, your liver doesn't divide, but if you get some accident and you cut some loop during surgery, if you get hepatectomy and you cut some loop of the liver, so in this condition, the liver will turn from stable to labile cells and start to compensate and restore the real number of liver cells. But labile cells, it's always dividing, like your skin cells. Each 3 or 4 days, your skin are regenerated. So skin cells, it's always dividing. So if I ask you, hypertrophy, hypertrophy happen or occur in which type of cells? Hypertrophy increase in size, not number. Of course, in permanent cells, because hypertrophy, the number of cells the same, but the size is large, but the number of cells is the same. But hyperplasia, no, the number is not the same. During hyperplasia, the number of cells will be increased. So hyperplasia occurs in stable and labile cells. Stable and labile cells. So hypertrophy mostly in non-dividing permanent cells. But hyperplasia, it's increased in number of cells. So site it occurs in labile and stable cells, cell which have the ability of division, not in permanent cells. Hyperplasia also we have physiological and pathological, but here pathological it's more common. Physiological hyperplasia, do you remember when I told you that during pregnancy, the ovary start to secrete progesterone and estrogen, and progesterone can cause increase in size of uterus, so it's called hypertrophy. And also estrogen increase number of endometrium cells, so estrogen can cause hyperplasia, because when we study pregnancy, we will say that we will talk about the progesterone and the estrogen. Progesterone increase the size of the cell, the size of glands, but estrogen will increase the number of glands, the number of cells. So progesterone can cause hypertrophy of the uterus, but estrogen can cause hyperplasia of the uterus. And also estrogen can increase the number of the duct, and here we have some, this is the breast, and here we have some ducts which form the milk. So the estrogen will increase the number of these ducts. So estrogen also physiologically can cause hyperplasia of endometrium and breast. And we will talk about pathological. We will say that estrogen within limits in normal range can cause hyperplasia normally in uterus and breast. But if you have increase in estrogen, and we will study in gynecology, if you have a very large amount of estrogen, it can transform the hyperplasia in endometrium into cancer, and also the hyperplasia in breast into cancer. So the estrogen, it's a very dangerous hormone. So estrogen can cause physiological hyperplasia when it's secreted within limits. It can cause hyperplasia of endometrial cells. It can cause hyperplasia of breast cells. But we will study also during pathological hyperplasia that estrogen itself, estrogen also can cause pathological hyperplasia in endometrium and pathological hyperplasia in breast. So please don't be confused here, because we will say that example of physiological hyperplasia breast and uterine muscle during pregnancy. But also during pathological, we will talk about the hormonal pathological hyperplasia, endometrium and mammary gland inside the breast. It can get pathological hyperplasia due to estrogen. Estrogen can cause hyperplasia in the endometrium, and write down please that it's a precancerous tumor. What does it mean, precancerous tumor? It can, after some time, it can turn into cancer. It can turn into cancer. Also, inside the mammary gland of the breast, the estrogen can cause hyperplasia, but if the woman has a lot of estrogen, it can cause memory uh, memory or breast cancer. It also precancerous tumor. It's called memory hyperplasia. Memory hyperplasia. It's precancer. It can turn into cancer. And memory hyperplasia, it's old name. Now in new books, we call it fibrocystic disease. Why we call it fibrocystic disease? Here, that the normal breast. And here we have normal ducts. What is the effect of estrogen on ducts? Estrogen has three effects on ducts inside the breast. Estrogen can increase the amount of fibrous tissue, can form a lot of fibrous tissue inside the breast. So if we have a lot of estrogen, so it can cause, of course, fibrosis, a lot of fibers, and that's not good because fiber will compress on ducts. And also the estrogen in normal range, it can cause cystic dilatation. These ducts can cause dilatation of these ducts, but inside during abnormal amount will be a lot of dilatation, severe dilatation of ducts, and here fibers surrounding these dilated ducts, and increase also the number of glands inside these ducts. So here, what we call in pathology, if we have fibrous tissue surrounding some dilating ducts, we call it cyst. Cyst means that there is dilated area surrounding with fiber. It's called cyst. And because we have here fibers, so we call it fibrocyst. So we call the breast hyperplasia, the new name, we call it fibrocystic disease. Fibrocystic disease. So please don't be confused in exam, because maybe they can mention memory hyperplasia or they can mention fibrocystic disease. Why? Because fibrocystic disease, because estrogen can increase the formation of fibers inside the breast and also can cause dilatation of the ducts, and we can form cyst with fibers, so we call it fibrocystic disease or memory hyperplasia, the old name. And both of them, memory hyperplasia or fibrocystic disease and endometrial hyperplasia, they are very dangerous and they are precancerous. They are precancerous because estrogen can increase the number of cells too much, and after that the woman can get cancer. The third one, prostatic hyperplasia, prostatic in males. The prostate, prostate, of course, prostate. In old age men, they always have prostatic hyperplasia. Why? Because due to the effect of androgen, male sex hormone, then the androgen can increase the cells inside the prostate, and cause prostatic hyperplasia. But very important note here that prostatic hyperplasia can never turn into cancer. So if you get prostatic hyperplasia, so you have to thank your God, thanks God, I will never get prostatic cancer. Why you cannot get prostatic cancer if you get prostatic hyperplasia? Because prostatic hyperplasia occurs in 70 or 8 years old. So in 70 or 80 years old, of course, the old men, they don't have enough androgen like young people like you, because you have a lot of androgen, a lot of sex hormone, but after 60, 70 or 80 years old, you don't have enough androgen, enough sex hormones. So we know that sex hormones, they are the main stimulus which cause increase in number of cells, hyperplasia. So if you are 8 years old or 70 years old, you don't have enough androgen, so of course you will not get hyperplasia. So someone can ask me, why he get hyperplasia of prostate if you told me that he doesn't have enough androgen in old age? He doesn't have enough androgen, but he has metabolites of androgen. Of androgen. The androgen in old age men, the androgen, they are breaking down. They are broken down, and the old men, they have metabolites of androgen. So metabolite of androgen can cause prostatic hyperplasia, but of course within limit. They cannot turn this hyperplasia into cancer, because the androgen metabolites, they are very, very weak. But inside the women, estrogen estrogen is produced in very large amount in women. That's why the women, they can get cancer, because they still have estrogen. But the men, they don't have androgen in old age, because androgen are metabolized. So they can get prostatic hyperplasia, but they cannot get prostatic cancer. That's why prostatic cancer is more common in young age, not in old age, because young age, they have a lot of androgen. So androgen can cause a lot of hyperplasia inside the prostate, but the old age, they don't have a lot of androgen, so cannot they cannot get prostatic cancer. Also, in thyroid hyperplasia, we will study some disease called goiter. Goiter means that pituitary gland increase TSH so much, a lot of TSH. And when we study endocrine system, we will know that TSH increase the size of thyroid gland and the number of thyroid glands, and increase the blood supply to thyroid gland. So if you have a lot of TSH, so TSH will go to thyroid gland and stimulate hyperplasia of thyroid gland and increase blood supply to thyroid gland, and the cells will start to increase in number. It's called goiter. So the first example of pathological hyperplasia, hormonal hyperplasia. Hormonal hyperplasia in women is more dangerous than men. In women, the estrogen, we know that estrogen can cause physiological hyperplasia within limit if estrogen is in normal range. But if estrogen is increased, so it can cause mammary hyperplasia or endometrial hyperplasia, and both of them, unfortunately, they are precancerous. But in men, prostatic hyperplasia due to androgen, it can never turn into cancer, because the old men, they don't have a lot of androgen. They have metabolite of androgen, but they don't have androgen. They have broken androgen. And also thyroid hyperplasia during goiter. In goiter, you have a lot of TSH. TSH will stimulate hyperplasia of thyroid gland. Another example of pathological hyperplasia, something called reactive hyperplasia. So first example, hormonal hyperplasia. Second, reactive hyperplasia. It appears in lymph nodes. Look at that. Can you see this enlargement? Here, increase of number of cells in lymph node. Why? In children, maybe you see before in hospital that some children they can get infection in oral in the oral cavity, and due to this infection oral cavity, some bacteria can enter to the lymph node behind the oral cavity, and the lymph node start to increase the number of cells. Why? Because there's invader, there's some bacteria get inside the lymph node, so the lymph node will start to increase the number of cells in lymph node to defend against this bacteria. So it's called reactive hyperplasia. And also you have irritation, chronic irritation. Chronic irritation, it's very common in urethral hyperplasia. You know, in urinary bladder, this urinary bladder, and here it's some vein which supply the urinary bladder. You can get some infection, it's called schistosoma, due to some ailments called bilharziasis. And we will study bilharziasis in details. Bilharziasis, they can penetrate the vein which go into the urinary bladder and can set. So here it's the epithelium of the bladder, and here they can set the bilharziasis inside the epithelium of the bladder. And this helminthes, bilharziasis, start to secrete inflammatory products, and they can irritate the epithelium of bladder. And here you have urine. So here you have urine. Normally, this site of epithelium does not face the urine, because urine, it's acidic. And this epithelium does not face the urine, so it doesn't know the acidic medium. After some time, the helminthes can irritate the epithelium and damage the epithelial tissue, and urine start to go to this epithelium the outer epithelium. So the epithelium will start to increase the number of cells to face this acidic medium. So this like nest. This like, you know, nest. Do you know understand what does mean nest? This nest is the house of the bird. So this nest where the bird can live. So why? Because here the cells of the outer epithelium are depressed, increase in number and depressed inside here. So it forms nest. The scientist who discovered this formation, his name is Brun. So it's called Brun's nest. Brun's nest. It occurs due to chronic irritation in urinary bladder. So when the epithelium of the bladder is irritated for a long time, so the epithelium will start to form a lot of cells and increase the number of cells to face this acidic medium of the urine, and form some nest called Brun nest. And so here the pathological hyperplasia. So let's start from the beginning. Hyperplasia we said it's increasing number of cells, increasing number of cells. Where can occur? Inside labile cells and stable cells, which have the ability to divide, but never occur in permanent cells, because permanent cells don't have the ability to divide. Permanent cells occurs during hypertrophy. Hypertrophy occurs in permanent cells. So hyperplasia can be physiological or pathological, but mostly pathological. Physiological, we said inside breast or uterine muscle due to the effect of estrogen. But estrogen itself can cause pathological hyperplasia of breast and uterine muscle if it increased in secretion. So pathological hyperplasia, we have hormonal hyperplasia due to effect of hormone, and we said estrogen, the commonest example. Estrogen can cause hyperplasia of the mammary gland or hyperplasia of the endometrial muscle, and both of them, unfortunately, they are pre-cancerous. But in men, prostatic hyperplasia can never turn into cancer because it occurs in old age, and old age means they don't have enough androgen to stimulate and turn the hyperplasia into cancer. And thyroid hyperplasia during goiter. And also we have another example, bone marrow hyperplasia. It can occur pathologically. How? You studied in blood in hematology that did the kidney, and here the bone marrow, and inside the bone marrow we have stem cells. When you have hypoxia, it means decrease in oxygen, and you know oxygen is carried on red blood cells. So this hypoxia stimulates some hormone inside the kidney. It's called erythropoietin. Erythropoiesis. Erythro means red blood cells. Poiesis means synthesis of red blood cells. So the process, it's called erythropoiesis. So the hormone, it's called erythropoietin. In means protein. Even protein ends with in. So erythropoietin, it's a protein hormone which stimulates erythropoiesis. So erythropoiesis will stimulate the stem cells inside the bone marrow to form a lot of red blood cells. So if you get some accident and you get severe blood loss, so of course you don't have enough red blood cells to carry the oxygen, so you will get severe hypoxia. So the kidney will start to produce a lot of erythropoietin, and erythropoietin will go to the bone marrow and start to stimulate bone marrow to secrete a lot of red blood cells. And bone marrow, of course, bone marrow, it's the factory, and the factory cannot work and produce that much of red blood cell. So the problem here that bone marrow will be in hurry. So that will start to secrete stem cells itself outside. Will start to secrete stem cells outside. Why? Because there's a lot of erythropoietin, and erythropoietin start to stimulate bone marrow, secrete please red blood cells and more red blood cells. After some time, bone marrow will say, I'm very sorry, I cannot secrete a lot of red blood cells, so take the stem cells outside. And of course, it's abnormal. It's abnormal. And then we take another example of pathological hyperplasia. It's reactive hyperplasia. It occurs inside the lymph node hyperplasia during infection. And chronic irritation, it occurs in bladder due to infection with bilharziasis and form bronze nest. So now we finish the hyperplasia, but now please, can you tell me what is the difference between hyperplasia and the cancer? Does hyperplasia means cancer or not? Hyperplasia means cancer or not? And if not, so what is the difference between hyperplasia and the cancer? I open the mic. So anyone knows the difference between the hyperplasia and the cancer?
Sir, basically, when we talk about the cancer cell, it is abnormal growth of the cells.
Yeah, pathological hyperplasia, I know, but pathological hyperplasia, it's not cancer. Pathological hyperplasia, it's not cancer. So why we cannot call the pathological hyperplasia cancer? Why? It's pathological, but we cannot call it cancer.
Because, sir, I think they may return to their original position like they were before.
Yeah, excellent. Yeah, excellent. Do you remember in the beginning of the lecture, we said that the adaptation, atrophy, hyperatrophy, hyperplasia, they are reversible. If you get rid of the stimulus, so the cells can come back to the normal structure. But you cannot say that the cancer cells cannot turn and come back to the normal structure. No, the only solution to get rid of cancer, to cut off the cancer. The cancer cells, they got crazy. They are crazy cells. They cannot come back to its normal nature. Again, what the second difference between hyperplasia and the cancer? Do you know another difference between hyperplasia and cancer? Huh? I open the mic. Guys, anyone know another difference between hyperplasia and cancer? Why we cannot call the hyperplasia cancer? First, your friend said that hyperplasia can come back to the normal structure, but cancer cannot. Another difference. In second lecture,
So
I will ask you.
hyperplasia may be controllable.
What?
Hyperplasia may be controllable, and cancer does not control this.
Not exactly, but okay. Let me show you. Here's some schedule. So here's the hyperplasia, and here the neoplasia or tumor, the cancer. First, hyperplasia is reversible, but of course, cancer is irreversible. Hyperplasia, it's self-limited, controlled. Just get rid of the stimulus, and then you can treat hyperplasia. For example, here in hormonal hyperplasia, in goiter, you have a lot of TSH. Okay, give something and treat the cause, and then the TSH will decrease. Then the thyroid gland will come back to the normal nature. So it's self-limited. We can control it, but in cancer we cannot control it. The only solution to cut off the cancer. Hyperplasia initiated by a specific stimulus. The abnormal stimulus, which cause the cell to be to get hyperplasia. But in cancer, you have a lot of factors. You have a lot of factors which can play a very important role to get cancer. And we will study oncology chapter, cancer chapter in details. Okay, metaplasia. So if I ask you, who know what does it mean, metaplasia? It's easy. I open the mic. Who knows what does it mean, metaplasia?
So it's change of one type of cells into another type of cells.
It's not complete definition. It's not. So okay, according to your definition, can you say that for example, epithelial tissue can be transformed into connective tissue and we can call it metaplasia, yeah? According to your definition. So epithelial tissue would be transformed into connective tissue, it's metaplasia, yeah? Yes or no?
Yes, sir.
Yes, sir.
Yes? Who doesn't, who, anyone has a different opinion? Can epithelial tissue transformed into connective tissue? For example, you have a squamous epithelial tissue, or for example, columnar epithelial tissue inside your bronchus, inside your bronchi. So can this tissue transform it into a bone? Because bone is one type of connective tissue. It's impossible. It's impossible. It's not logic. Metaplasia, transformation of cell into another type of differentiated cell within limits. What does it mean within limits? You cannot say that epithelial tissue can transform into connective tissue. No, it's impossible. Your epithelial tissue in bronchi cannot transform it into bone. It's not logic. It's not real. Cannot happen inside your body. So metaplasia, it's transformation of some type of tissue into another type of tissue. For example, epithelial tissue. Maybe in epithelial tissue you have a columnar epithelial tissue. Columnar epithelial tissue can transform it into a squamous epithelial tissue, but still epithelial tissue. So columnar can be transformed into squamous, but both of them, they are epithelial tissue. So metaplasia, transformation of tissue into another tissue inside the category. For example, epithelial tissue, we have a columnar epithelial tissue, a squamous epithelial tissue, transitional epithelial tissue. So squamous can be transformed into columnar, and the columnar can be transformed into transitional epithelial tissue, but all of them, they still epithelial tissue. But you cannot say that epithelial tissue can transform it into bone tissue. Cannot happen. So metaplasia, transformation of cell or tissue into another type of cell or tissue within limits. If you don't say within limits, I'll give you 0. So the type of metaplasia, we have 2 types of metaplasia. Metaplasia which can happen inside epithelial tissue, and metaplasia which can happen in connective or mesenchymal connective tissue. Mesenchymal, it's one type of connective tissue. And so we have epithelial metaplasia and connective metaplasia. Epithelial metaplasia, it's reversible, but connective metaplasia, it's irreversible. And when we see the example now, you will understand. First, let's start with epithelial metaplasia. Here we have a squamous metaplasia, and please remember, when I say squamous metaplasia, it means that this type of tissue, it's the new tissue. So when I say squamous metaplasia, it means there's some type of tissue which is not squamous, then transform it into squamous. So squamous, it's the new formed tissue. So examples on squamous metaplasia: 3S with 3B. 3S and 3B. It's, you can remember with 3S and 3B. First S is smoking. But first let's start with the difference between squamous epithelial tissue and columnar epithelial tissue. Which one is stronger, squamous or columnar? Huh? Can you tell me, please? Which type of epithelial tissue is more stronger, squamous or columnar epithelial tissue?
Columnar.
No,
Columnar, sir.
no, squamous. Squamous epithelial tissue. It's more stronger than columnar. But columnar have something which squamous doesn't have. Columnar, it's secretory tissue. What does it mean secretory? Columnar can secrete mucin, mucus. So columnar, when I ask you where the columnar epithelial is located inside your body, search about mucus tissue inside your body. Where do you have mucus tissue inside your body? In bronchus. Why we have mucus inside your bronchus? Because maybe you can inhale some bacteria or dust. So the mucus tissue inside your bronchus protect the bronchi. So the epithelial tissue inside the bronchi, it's columnar. In stomach or intestine, the stomach tissue or intestine tissue, they secrete a lot of enzymes, a lot of mucus. Inside the stomach, the tissue in stomach secrete mucus to protect the stomach against HCl. So the epithelial tissue in the stomach is columnar. So maybe you ask if squamous epithelial tissue is stronger than columnar. Why stomach has columnar epithelial tissue? We know that stomach has very, very strong acidic medium. So if anyone asks you, tell him that columnar is not stronger as squamous, but columnar secrete mucus tissue. So the stomach has columnar epithelial tissue because columnar can secrete mucin, which can neutralize the HCl in the stomach. So columnar can face the acidity, but squamous cannot. Intestine, we know that intestinal tissue secrete a lot of hormone, a lot of enzyme. So the epithelial in intestine, it's secretory. So it must be columnar. Okay, so the epithelial tissue inside your bronchi, it's columnar. It's columnar. But during smoking, you have a lot of irritation. So the columnar epithelial tissue cannot face this irritation. So the columnar will say, "Oh, I'm very sorry. I have to transform it into another strong epithelial tissue who can face this irritation." So the columnar will turn into squamous epithelial tissue inside the bronchi. So we called squamous metaplasia. Squamous metaplasia. So is it reversible? Of course. Stop smoking, and then the squamous metaplasia will die off and then transform into columnar. And remember, very important note. During metaplasia, here inside the bronchus, you have this columnar epithelium. Does columnar epithelium itself transform into squamous? No. So what's transformed into squamous? The stem cell. Stem cells, the mother cells, which form columnar epithelium. This inside normal person. But smokers, the stem cell, the columnar epithelium will not transform into squamous itself. No. After some time, when this columnar epithelium, which already formed, will die off, the stem cells will not secrete columnar, will secrete squamous. So metaplasia doesn't affect the exact epithelium. No, it affects the genes of stem cell. So after the columnar epithelium die off after some days, because we always regenerate the epithelium inside your body. So columnar epithelium itself will not transform into squamous. But after 1 or 2 weeks, this columnar epithelium will die, and stem cells got affected by irritation and smoking. So stem cell will start to secrete squamous epithelial tissue. Okay. So is it reversible? Of course, reversible. Just stop smoking, and then stem cells will come back to nature and start to secrete columnar epithelium. Okay. The second is, so here S smoking, B bronchi. The second S and the second B. So here smoking and bronchi. Bronchi, columnar epithelium will turn off squamous epithelium. Second one is schistosoma inside the urinary bladder. You remember when we said in hyperplasia, when we said that there's the bladder, and here you have irritation with bilharziasis, and then the epithelium will start to form bron nest. After some time, after irritation and the chronic irritation for a long time of these cells, what's going to happen? This tissue cannot face the urine for a long time. The tissue inside the bladder, it's called transitional. What does it mean, transitional? It means the epithelium which can expand to contain the urine. So this type of cell of tissue will transform into a squamous epithelium, because this tissue will be irritated for a long time, and the tissue will say, I'm sorry, I cannot face this irritation, so I have to turn and transform into more stronger epithelium, so it will transform into squamous epithelium. So it's called squamous metaplasia of bladder. The third S and B, bladder. And you have two bladder, urinary bladder and the gall bladder. S, stones. Stones can cause irritation of gall bladder or urinary bladder, and the epithelium inside the gall bladder, it's columnar because it secretes the bile. And here the epithelium inside the urinary bladder, it's transitional. Both of them, they can transform into squamous to be able to face the irritation of stones. So here we have S, smoking, B, bronchi, S, schistosoma, B, bladder, urinary bladder, S, stones, B, bladder, urinary or gall bladder. Also, we have squamous metaplasia of nasal epithelium. The nasal epithelium, we have mucus inside the nose, so it's a columnar epithelium. After chronic irritation, this columnar epithelium cannot face the irritation, and then will transform into more stronger type of tissue. It's called squamous. And also we have in cervix of the uterus. Here, let me show you some photo. Here it's the endometrium, of the uterus, and here it's vagina. And the cervix of the uterus, it consists of two parts. The part which inside, which face the endometrium, it's called endocervix, and the part of cervix outside, it's called ecto or exocervix. Which one of them must be more stronger? Of course, the exo. Why? Because the exocervix, it's near the outer environment, and during sexual intercourse, the penis will go inside the vagina. So this part of the cervix must be more stronger to face the friction of the penis, or also to face the irritation which coming from the outer environment. So the exocervix, it's similar of to the epithelium in vagina, because also vagina, it has a squamous epithelium. So exocervix, it has also squamous epithelium. But here in endometrium, we know that endometrium secrete hormones, a lot of hormone and a lot of nutrients to feed the fetus and also to feed the sperm. So these epithelium must be secretory, and the endocervix is similar to the epithelium of endometrium. So the endocervix has columnar epithelium, and the exocervix has squamous epithelium. Exocervix has squamous epithelium to face the outer environment, and the endocervix has columnar epithelium to secrete nutrients for sperm. So during cervices inflammation of cervix, during inflammation of the cervix here, if the bacteria go inside and affect the endocervix, what's gonna happen? The endocervix epithelium, which is columnar epithelium, will say, "Oh my God, I have a lot of infection. I have a lot of infection and bacteria. So I have to transform it into more strong epithelium, which is exocervix, squamous epithelium, like the epithelium of the exocervix. So exocervix, it's naturally squamous, but endo, no, it's columnar. After infection affect the exocervix, and the infection can go inside the endo, so the endo also will transform it into squamous epithelium to be able to face the infection which coming from the exocervix. So squamous metaplasia, we have 3S with 3B. S smoking, B bronchi. S schistosoma, B bladder, urinary bladder. S stones, B bladder, gall and urinary bladder. And we have chronic nasal polyp. Polyp means like the accumulation of squamous epithelial tissue inside the nose after getting infected. And endocervix, which naturally has columnar epithelium, but during cervicitis, inflammation of cervix will transform it into squamous epithelium. So it's called squamous metaplasia. So we say that metaplasia is transformation of one tissue into another tissue within limits. Epithelial tissue will transform it into another type of epithelial tissue. And we talk of epithelial metaplasia. First, epithelial metaplasia, we have squamous metaplasia. Then we have second type, it's columnar metaplasia. And columnar metaplasia, example of columnar metaplasia, this, the esophagus, and here is the stomach. When you eat the food, of course, the food will make friction with the esophageal wall. So the esophagus epithelium must be squamous. So here should be squamous. Why? Because the food will come and make friction with the epithelium, so we need very strong epithelium. But the last part of the esophagus, which is very near to the stomach, it should be columnar. Why? Because when the sphincter of the stomach open, some HCl maybe can go out. So the distal end of the esophagus must be columnar. Why? Because columnar is secretory. So if some HCl go to the esophagus in this part, so the columnar epithelium can secrete bicarbonate, which can neutralize HCl, which can get rid of HCl, and also mucin, it's alkali, which can neutralize the HCl. And some disease called gastro esophageal reflux disease, GERD, gastroesophageal reflux disease. This sphincter between the esophagus and the stomach, it's a failure to close. So HCl will go in all esophagus. So this is squamous in red color. Will say, oh my God, I cannot face the HCl, so I have to transform into my brother, columnar epithelium. Why? To be able to face the acidity which coming from the stomach. And this is the only example in your body when weak, strong epithelium can transform into weak epithelium. A strong epithelium like squamous will transform into weak epithelium like columnar. Why? Because columnar can face HCl, can resist HCl. And it's called GERD. Another example. This the stomach, and here it's intestine. In microbiology, we will study some bacteria called Helicobacter pylori. Helicobacter pylori love stomach. Helicobacter pylori can live only in stomach. Why? Because inside the stomach they have here columnar epithelium, and this columnar epithelium, it's called gastric columnar epithelium. Why we call it gastric? Because it's different than intestinal columnar epithelium. It's also columnar, but it's different. Different in what? Helicobacter pylori loves to live in the stomach because gastric columnar epithelium secrete a specific mucin, a specific type of mucin, which this bacteria can eat it. That's why Helicobacter pylori want to live inside the stomach to get this specific type of mucin, which is secreted from gastric columnar epithelium. So Helicobacter pylori will come here and live inside the epithelial tissue of the stomach, which is columnar. After some time, Helicobacter pylori will cause chronic painful irritation in the stomach. So the columnar epithelium in the stomach will start to transform it into columnar epithelium, but in intestinal columnar epithelium. So in this type, columnar epithelium will transform it into columnar epithelium, but here gastric columnar epithelium will be transformed into intestinal columnar epithelium. Why? Because intestinal columnar epithelium doesn't secrete the specific mucin which Helicobacter pylori can eat it. So gastric columnar epithelium will transform into intestinal columnar epithelium because this bacteria cannot live within intestinal columnar epithelium. So it's called columnar metaplasia also. So first one, when the squamous epithelium inside esophagus transformed into columnar epithelium to resist HCl. And second type of columnar metaplasia when the gastric columnar epithelium transformed into intestinal columnar epithelium. The last example in columnar metaplasia, it occurs in bladder. Also, you remember schistosoma? You remember schistosoma? When we said that here some bronze nest will form inside the urinary bladder. After some time, this nest will get down more, and of course here a lot of fibers are around the nest. So this part will not get enough blood supply because here blood supply cannot penetrate this fiber. So this part of nest will not get blood supply and will start to die off, and then will be empty, and this transitional epithelium will start to turn into columnar glandular epithelium. What does it mean? Columnar epithelium has a specific type, it's called glandular epithelium. Why we call glandular epithelium? Why transitional epithelium here transformed into columnar? To secrete mucin and bicarbonate to face the acidity of the urine. And why we call it glandular? Because it's similar to the gland in shape, because in glandular epithelium we have like columnar epithelium, and inside it's called colloid. Colloid means empty space inside the gland. So here it's empty because there's no blood supply, and the tissue here will start to die off, and this type of fiber of epithelium will form into columnar to secrete bicarbonate and mucin to face the acidity of the urine. So it's a columnar metaplasia. And here it's like cyst, like, because we said cyst. What does it mean, cyst? Cyst means you have epithelium and inside it's empty. It's called cyst. That's why we call it cystica of the bladder. We call it cystic cystitis. Cystitis means inflammation, because bilharziasis caused inflammation, and cystic because it transformed into a structure like cyst. That's why we call it cystitis. Cystitis means inflammation of bladder. Cystica. Cystitis means inflammation, which leads to formation of cyst. So columnar metaplasia in esophagus during GERD, and also in stomach, gastric columnar epithelium will transform into intestinal columnar epithelium. And also in cystitis cystica, when this nest structures inside will start to die off, and outside the transition epithelium will transform into columnar. So columnar, and inside it's empty like cyst or gland. So we call it columnar glandular epithelium. So it's a columnar metaplasia. So all types of epithelial metaplasia, it's reversible. We can get rid of the cause, and the cells will come back to the nature structure. For example, if you are a smoker and you have a squamous metaplasia, if you stop smoking, then this metaplasia will come back to the nature and will come back to the columnar epithelium. Second type of metaplasia, it's called mesenchymal or connective tissue metaplasia. Connective tissue metaplasia. Mesenchymal, we have three examples in mesenchymal metaplasia, and it's irreversible. It's irreversible. And from the example, you will understand why it's irreversible. First example, in osseous connective tissue. In os means bone. Osseous metaplasia. Oh my God, osseous metaplasia? You mean that some tissue, some connective tissue will be transformed into bones? Yeah. First example, it's myocytes ossification in muscle. Ossification means bone formation due to myocytes. Myo means muscle. ITIS, inflammation. Inflammation in muscle can lead to formation of bones. How? You know, in athletes or horse riders or bodybuilders, they always put a lot of pressure on the muscle. And after some time, specifically in horse riders, the muscle can get some injury and some inflammation due to a lot of trauma to the muscle. After that, some fibers inside the muscle will start to die off, and inflamed. After inflammation, inflammatory cells will come to this place to get rid of inflammation. You have some immune cells, inflammatory cells called macrophages. Macrophage will come to the inflammatory site to eat and engulf the inflammatory products. But unfortunately, the macrophage can produce something called growth factor. Growth factor can lead to formation of bony tissue. So growth factor can attach calcium together and form calcified area, and this calcified area then will transform it into bones, because calcium, when collect together with the effect of cells, will form bony tissue. So it happened first because of inflammation, the inflammation of the muscle. Then the immune cells will come to engulf and kill the inflammatory site. Unfortunately, the macrophage will produce growth factor, and growth factor leads to bone formation. And after some time, when you go and make x-ray, you will find some bone formation inside your muscle. In love of God, please tell me, can this bone tissue come back normally into muscular tissue? Of course, no. The only solution to resect this bony formation. So the only solution to intervene surgically and get rid of this bony formation. So that's why it's irreversible. That's why mesenchymal or connective tissue metaplasia, it's irreversible, because here we cannot transform the bony tissue again into muscular tissue. It's impossible. So it's called myocytes ossification in muscle. Why we call it like that? Because it's ossification, formation of bones due to inflammation of muscles. Inflammation of muscles. Then the inflammatory cells will come to get rid of this inflammation, and unfortunately, one of them called macrophage will secrete growth factor, and the growth factor will cause ossification in muscles, for bony formation in muscles. Second type of osseous metaplasia, it's called ossification of calcified area. We know that, and we will study in necrosis, that some tissue after dying, the calcium will be deposited inside these dead cells, and calcium together will collect inside the dead cells, and with help of some cells called osteoblast. Osteo means bone, blast means building. The cells which can build bone will come to calcified area and start to form bone tissue. So it's called ossification of calcified area. Calcified area, the dead necrotic area, has a lot of calcium deposit inside it. So osteoblasts will come, and of course, osteoblast plus calcium, then we can form bone. And the last example of osseous metaplasia, ossification of tumor stroma. Oh my God, can tumor transform it into bone? Yeah, because the crazy cells in tumor, these tumor cells, they always surround themselves with stroma. Stroma means fibrous tissue. So after that, with help of some growth factor and cells like osteoblast cells, they can come and form this fibrous tissue into bony tissue. So mesenchymal or connective tissue metaplasia, the first type, osseous metaplasia, formation of some tissue, of some connective tissue into into bone, like myocytes ossification in muscle, ossification of calcified area, ossification of tumor stroma. Second type of mesenchymal metaplasia, it's called cartilaginous metaplasia. So some connective tissue will transform it into cartilage tissue. It's very common in spleen. Why? We know that, do you know the relation between the liver and your spleen? The relation between them, that splenic vein always drains the blood inside the hepatic vein. In some liver diseases like liver cirrhosis, the liver will be shrinking and compress the hepatic vein, so the splenic vein cannot drain cannot put the blood from splenic vein into the hepatic vein, and then the blood, of course, will come back to spleen, and spleen will accumulate it with blood. And we know that spleen has a splenic capsule which surround the spleen. Due to accumulation of blood inside spleen will start to get bigger and bigger and bigger and bigger, and cause something called splenomegaly. Splenomegaly means enlargement. So this splenic capsule cannot contain and cannot protect the spleen. The spleen will be ruptured. The spleen will rupture. So what's gonna happen? So splenic capsule will say, "Oh my God, I have to transform it into very firm and strong tissue to be able to contain and inhibit and prevent the spleen from getting bigger and bigger." So a splenic capsule which will be formed into cartilaginous tissue, cartilage, into cartilage, and of course it's abnormal, so it's called cartilaginous metaplasia and occur during splenomegaly. And the last example it's of mesenchymal metaplasia, myeloid metaplasia. What does it mean, myeloid metaplasia? Myeloid tissue, we have myeloid tissue inside bone marrow. Here in the bone marrow, and here we have some cells called myeloid cells, the mother cells of the blood cells, the cells which can differentiate into the whole types of cells: red blood cells, white blood cells, platelets, all type of cells. During severe blood loss, the liver will try to compensate. Why? Because the bone marrow cannot compensate that severe blood loss. So the liver will come and say, "Hey, I will help you to produce some blood cells." Oh, what the heck? Yeah, I will help the bone marrow to produce blood cells. So I will transform some tissue into myeloid tissue to help secretion of blood cells. So it's called myeloid metaplasia of the liver. Why? To compensate with severe blood loss, because the bone marrow cannot compensate that severe blood loss. So the liver would say, "Don't worry, I'm gonna help you. I will transform some of my tissue into myeloid tissue." So this is the last example. So let's take a quick review and then we finish. I know it's a very big and long lecture, but don't worry, you have the record, then you can watch it many times and you have the PDF. So here we say that in adaptation, that the cell will be adapt due to some changes in your body. How it can be adapted by increasing size, increasing number, increasing function, or type of cell metaplasia. These changes can be physiological and pathological, and we have 4 features of adaptation: atrophy, hypertrophy, hyperplasia, metaplasia. The first three features, atrophy, hypertrophy, hyperplasia, they can be physiological or pathological, but metaplasia cannot be physiological. The type of tissue cannot be transformed into another type of tissue, and we call it physiological. Of course, it's pathological. So atrophy decrease in size and or number of cells, and we said physiological like thymus, appendix, ovaries. Pathological, we said like ischemic atrophy, pressure atrophy, neurogenic atrophy, disuse like in immobilization of muscles, hormonal atrophy, nutritional atrophy like in marasmus, severe protein starvation, and hypertrophy, we said it's increase in size, but hyperplasia increase in number. Hypertrophy, it happens in non-dividing permanent cells because the number of cells does not increase, just the size of cells, and mostly physiological. And hyperplasia increase in number, and it happens where in the bile and stable cells, and it's also physiological and pathological, but mostly pathological. And we said pathological, like hormonal, like in estrogen, can cause mammary hyperplasia or endometrial hyperplasia, and androgen can cause prostatic hyperplasia. But in women, mammary and endometrial hyperplasia are precancerous, but prostatic hyperplasia can never turn into cancer because the old men, they don't have androgen to stimulate more and more hyperplasia. And also thyroid hyperplasia like in goiter, and the bone marrow hyperplasia during severe blood loss. The second type of pathologic hyperplasia, reactive hyperplasia, when lymph node during infection. If you got infection, the lymph node cells will be increased in size, increased in number to produce a lot of lymphoid cells. And chronic irritation, like we said in bronze nest, that the epithelial tissue of the urinary bladder will increase in number to resist the acidity of the urine. And we said also we talk about the metaplasia and its transformation of some tissue to another tissue within limits. Columnar epithelium can transform into squamous, and the squamous can transform into columnar, but still epithelial tissue. And we talk about two types of metaplasia. It's epithelial and mesenchymal. Epithelial, we have squamous metaplasia, and we have columnar metaplasia, and in mesenchymal we have osseous metaplasia, cartilaginous metaplasia, myeloid metaplasia. Epithelial metaplasia, it's irreversible. If you are a smoker, when you stop smoking, the squamous epithelium will come back into nature, into the columnar epithelium inside the bronchi. But mesenchymal metaplasia, it's irreversible. You cannot say that bony tissue inside the muscle can come back again into muscle. So mesenchymal metaplasia, it's irreversible. We have osseous metaplasia, cartilaginous metaplasia, myeloid metaplasia. So we finished today. I hope you enjoyed the class. And if you have any question, go ahead. Or if you have any comment or anything, you are completely welcome.